next witness to provide expert testimony is Dr. Sean Studer.
Dr. Preston, please call your witness.
I'm calling Dr. Studer. Dr. Studer, let's review the typical side effect profile of prostacyclin therapies, please.
Oh, it's significant. Prostacyclins, for all their benefits, have patients that have to contend with quite a list of side effects. They would include, for example, jaw pain, headache, leg pains, any number of gastrointestinal side effects from nausea, anorexia, vomiting, diarrhea. They can also have thrombocytopenia, low platelet counts. And then there's issues with the delivery system. They can get line sepsis from their indwelling catheters of thrombparenteral. They can get clots. That's not exhaustive, but it just shows the breadth of issues of treating with this group of therapies.
So they're not uncomplicated therapies to use?
No, they are not.
What are the other risks associated with prostacyclin therapy, thinking of the non-parenteral formulations?
So really with the non-parenterals, you don't have the delivery system complications, right? So if there's no catheter in for an IV therapy, you can't get infection of the catheter, you can't get clots. Similarly with a subcutaneous or an inhaled, you can't have delivery system complications. But the remainder of the list still affects most of the prostacyclin therapies in most patients. They will experience all the GI side effects I mentioned, the jaw pain, low platelet counts and things. So it's not completely changed.
And then going back to infusion therapies, what are the problems that can arise regarding the mode of delivery?
So the delivery systems are somewhat complicated themselves. Many patients can manage it, but for example, there's often up titration, meaning you don't just have one dose, you start out, you need to change the dose over time. So there's a lot of communication involved. You need to monitor for that side effects as you up titrate. If you have an infusion device, you have a pump to manage, you have medication to prepare each day. There's a lot of steps that make it more complicated than, say, taking a pill in one of the other categories of therapy.
Can you review with us the infection problems associated with parenteral delivery system?
Sure. As I said, they're not insubstantial. So infection rates have been estimated from about 0.4 to just over 1 infection per 1,000 treatment days. So if you have it in for 3 years, there's a chance that some people will get infected. If you have a number of people for a year in your practice, you're going to likely see infections, even with ideal technique. It seems to affect both of the infusion prostacyclins, and they can get infected during other daily activities, bathing, showering. Patients will sometimes try to cover them and go swimming. So it's not insubstantial, the concerns that can happen with these lines and subcutaneous devices.
Thank you, Dr. Studer. So let's move on to discuss the studying of functional class 1 and 2 patients on prostanoids. Are there any data on functional class 1 patients?
Not really. It's not been a focus to study functional class 1. They're difficult to detect. Every once in a while, 1 or 2 will pop up in a study, but there isn't really a focused amount of data to discuss for prostacyclin in functional class 1 patients.
How about functional class 2?
Functional class 2, there's more, but I wouldn't say it's a focused experience. So often they're mixed between functional class 2s and 3s. And as I might have said before, a functional class 2 to me might be a functional class 3 to someone else. So when you look at some of the functional class 2s, I don't think you're really talking about a functional class 1 and 2 group as we're focusing on today. You're talking when you do 2s only a sicker group.
If we look at the large event-driven trials, such as Ambition, Seraphim, and Griffin, did they include functional 1 and 2 patients?
So to my recollection, Ambition did not. Seraphim may have had 1 or 2 that were not really intended to be in the trial, and Griffin had a small number. I think it was less than a dozen that were exposed. So as a yes or no, there may have been a few, as I mentioned earlier, but it's certainly not an experience one can draw from to discuss functional class 1s.
Functional class 1s. So let's discuss a little bit about Ambition. What were the exclusion criteria for patients to be enrolled in Ambition?
So Ambition was a noteworthy trial, but the exclusion clearly stated that if someone had previously received a pH therapy, including a prostanoid with 4 weeks prior to the screening visit, they could not be enrolled in that trial. So it did not include prostacyclins. In fact, if you had been treated previously in the recent past, you were excluded from even participating.
But they did include functional class 2 patients.
They did.
So looking at functional class 2 patients, I know you are aware of the new analysis of the AMBITION trial that breaks down patients depending on their risk for worsening and mortality. Can you present to us the results of this particular paper?
Sure. So this study that was published by Dr. Adani Frost as the first author in the Journal of Heart-Lung Transplant examined the population in AMBITION and asked as a post hoc or after the study was done the real question of could you risk stratify those patients, and they used a validated tool called the REVEAL Risk Calculator, and they looked at lower risk, average risk, and higher risk patients, and one of the things that it determined was irrespective of risk category, you did better on combination therapy than you did on monotherapy. But I think the message here is also that you could risk stratify those. So all of the functional twos were not the same, for example, when you applied the REVEAL Risk Calculator. You got a substratification that we think is valid.
And what were the results? How did low-risk patients perform on 2 combination therapies that did not include a prostacyclin?
It was impressive. So they looked at time to clinical failure or another event in the trial. And the functional class 2s who were low risk had no events on those 2 therapies, and as you mentioned, there was no prostacyclin included. So they, over that trial, which was not a few weeks, it went on for years in some patients' participation, there was no deterioration and no clinical events in a non-prostacyclin combination treatment path.
So then looking from the other angle, can we identify those functional class 2 patients who may benefit from additional therapy with PGI2 and not put everyone in functional class 2 on prostacyclin therapy?
I would say yes. You know, if I go to the supermarket and I'm trying to buy ripe bananas, I can tell which ones are ready to go and which ones need a few more days. And I think the risk calculator in this told us which in the functional class 2s had a very low risk of progression and which are those that were likely to deteriorate and would be candidates. So yes, it did give us the ability to distinguish within functional class 2 in my view.
So in AMBITION, what was the proportion of functional class 2 patients who were found to be at high risk by the REVEAL Risk Calculator?
That's a great question. It was a real minority. It was only 10% of functional class 2s that were thought to be high risk. So the majority fell into an average or lower risk category in functional class 2.
Have there any studies been done focusing solely on functional class 1 or 2 patients with a prostanoid therapy?
Not to my knowledge. The last even focused functional class 2 probably goes back to the early trial of an endothelin receptor antagonist. So I cannot think of any significant trial that focused on this population.
Can you remind us in the Griffin trial that used a prostacyclin analog, how many functional class 1 and functional class 2 patients were enrolled?
So if memory serves, the functional class 1 were about 9. And that might sound as a rare disease, but there was almost 1,200 patients, 1,156 patients. So 9 of over 1,000 were functional class 1s. And the functional class 2s were a bigger group. That was more of the target, arguably, 529 of that 1,156.
So basically, this is the extent of the data that we have available for functional class 1 and 2 patients.
Yes, it is.
So in the setting of a good functional patient, 1 or 2, most of them have jobs, they're active in their community and their families. Given the unclear benefit of the prostacyclin treatment, how do you see the impact of their quality of life by using medications that are very cumbersome and complex to use?
So that's a great question as well. If we're going to think that we can take this group of therapies that does not have, I think, well-established data right now and apply it broadly across functional class 1 and 2s, the risks of it or the burden is quite important. There was a paper that addressed this recently. Not surprisingly, it depended largely on the type of delivery. So those who were on a parenteral delivery had a substantial self-reported burden of treatment. Those that were on oral therapies had less. But in everyone, there was some reported burden of therapy. The symptoms and the side effects that sometimes occur on these treatments can be substantial. So that would have to be considered if they're applied without clear-cut data broadly across classes.
Thank you, Dr. Studer. Thank you, Your Honor.
Thank you. Dr. Sagar, would you like to cross-examine?
Dr. Studer, before I ask you the questions I had prepared, you brought up your analogy regarding the bananas. So I'd like to kind of take that forward a little bit. So if you
Counselor,
bought,
let's just keep this brief.
can I get some latitude, sir?
It's allowed.
Thank you. If you bought raw bananas and you brought them home and you wanted to wait for them to ripen, assuming you're going to end up eating those bananas, would you want to put those bananas in the cold, refrigerated environment, or would you actually nurture them in the warmth of your kitchen and let them actually ripen so you could actually enjoy that banana?
Your Honor, they should go to poetry class or literature.
Well, my argument
but
here
not
is simple,
here.
that if you're a functional class 2 patient, i.e. a banana that's raw, okay, you can either watch it ripen in a way that you will actually get clinical success, functional class, improved functional class, let's say 2 to 1, get improved functional capacity. These patients have PAH. We know it's a deadly disease. You wouldn't want to place it in an environment such as with a suboptimal regimen, initial combination therapy with a non-prostanoid, and that's my only point.
Other than saying that my patients are not bananas, there's a few that are a little bit eccentric. I don't really know how to respond to that.
All right, let's move on. I think you got my point. In a disease such as PAH with significant morbidity and mortality, would you agree that it makes sense to treat as early as possible if you're lucky enough to find a functional class 2 patient?
I would agree that applying treatment early in disease is beneficial, yes.
Okay, and do you think that the functional class 2 patient that you're currently finding in your practice, I mean, who are these patients? They first have to come to clinical attention. So they tend to be patients that are screened populations. For instance, a connective tissue disease patient or a portal pulmonary hypertension patient. Would you agree?
They are a referral population, but I would say that there are some who are on the milder end of functional class 2. So I think there's a mix. But yes, as a referral population, there are some sicker functional class 2s, and I think probably the real registry, real risk calculator rather, would bear that out.
Okay, the opposing counsel suggests that really only a minority of functional class 2 patients, the AMBITION study had a morbidity or mortality event in follow-up. We learned that that was probably 20% of the patients, 1 out of 5. You have to admit the follow-up period was short, and long-term outcomes are really unclear. I mean, you mentioned that these patients are followed out a significant amount of time, but what we're really interested in is how long these patients are going to survive and what's going to happen to them years down the line. I mean, regardless, let's face it, our PAH patients are not living long enough as we practice today. Would you agree with that?
I would agree there's substantial opportunity to improve their quality and length of life, yes.
And would you agree that that opportunity exists in the early disease functional class 2 patient as well?
I would agree there's an opportunity there, yes, especially in those that are naive or untreated, yes.
In your practice of medicine, do you ever extrapolate randomized placebo-controlled trial data to similar or related patient populations?
So I would say that it's not unusual in medicine for myself or my colleagues to extrapolate data, to look at a study that was done in one area, and for an individual patient in front of me to think they might fit a group that's similar to that. I would not, however, generalize. I wouldn't necessarily take the entire group of patients like that and just automatically or reflexively put them all on a prostacyclin.
So as we sit here today, you agree that the prostacyclin pathway does have a role in a group or subgroup of functional class 1 and 2 patients?
Right.
Excuse me, Honor, did you see that?
No, I did not. I'm sorry.
Permission to treat the witness as hostile?
What's going on here?
Sorry, Your Honor. My final question is that if you had PAH due to systemic sclerosis and functional class 2 symptoms, you personally, would you personally want a prostanoid as part of your initial regimen?
I would be inclined to want a prostanoid, yes, given that.
And why would that be?
Because I think the complexities involved are something that my training would prepare me to handle. I'd be very well schooled in the side effects and the burden that would take on. So I think I would be inclined. I can't say for sure that I would request it. If you were my physician, which is probably not likely, but if it were possible, but I might want it.
Are you saying that you could handle the complexities of this therapy better than our standard patient population? Are you smarter than our standard patient? Is that what you're saying?
No, I don't think I'm smarter than them, but I do think there's something to be said about knowing what you're getting yourself into in a way. And so I think if my risk score, you gave me a scleroderma diagnosis, which I don't appreciate, by the way, I think there's a higher risk possibility that you want to address. But if you asked me if I was a functional class 2 and I came into your office and I was otherwise stabilized and good meeting goals on non-prostacyclin functional class 2, maintained good walk distance, all the things that we desire for our patients, I'm not so sure I would run to a prostacyclin immediately.
I think you made my point, Dr. Studer. Thank you.
Oh, Your Honor, can I redirect? Are you done, opposing counsel? Thank you.
You talking to me?
Yes.
Yes.
Yes, briefly.
Briefly, can you briefly summarize your recommendations regarding functional class 1 and 2 and prostacyclin therapy, Dr. Studer?
Sure. So to start from the top, and the council mentioned that this is an evidence-free zone, we really don't have functional class 1 data to stand on to argue that prostacyclin should be provided there. And I think for functional class 2, an argument that we should generalize and give most patients a prostacyclin pathway therapy is still shaky ground at best. They can be cumbersome, they can be associated with treatment side effects, and I think if we have trials that are waiting to give a definitive evidence-based answer to this, that we should be very cautious and largely wait for that evidence to present itself before we make this a somewhat standard practice.
Thank you, Dr. Studer. Thank you, Your Honor. I'm done with the witness.
Thank you. I'd like to thank both our attorneys and both our expert witnesses. And Dr. Sagar, would you like to enter your summary judgment?
That concludes expert testimony from witnesses. Please watch the next episode to hear the closing arguments.